Welcome to Atrium Health Navicent Knows Health. I'm Cindy Busby, and I'm here today with Dr. Marcus Evans. He's a board-certified radiologist, and he's also fellowship trained in neuroradiology. And today we're going to talk about his practice in Central Georgia. Dr. Evans, thanks so much for being with me.
Thank you for having me.
Would you tell our audience a little bit about the full specialty of radiology? We know you have a specialty within that we'll talk about, but what is radiology when a patient hears that?
Radiology is the use of imaging of the body to obtain diagnostic information to help the patient's clinician determine, or differentiate between what's going on with them clinically.
Mm-hmm. And when it comes to being a radiologist, you all act in partnership with some clinicians who are asking you for more information.
Right.
But you also have standalone interventions and treatments that you do.
That's correct.
As well. Tell us a little bit about, just briefly, what are some of the modalities in diagnostic radiology that you participate in examining and giving information to other clinicians for?
Well, the sort of go-to one that everybody knows about is plain radiology, which is just x-rays. Mm-hmm. And then beyond that, there are higher modalities such as CT scanning, which is actually creating slices through anatomy of interest. MRI, which is a very high resolution, extremely beneficial, or not beneficial, but sensitive exam. Mm-hmm. That does not use radiation. So it saves the patient from exposure to radiation. And then there are other studies, nuclear medicine, which is more of a, looking at the physiology of the body, and ultrasound and fluoroscopy, things like that.
Mm-hmm. So with those being the modalities where you can help make diagnoses, the other piece is where, as a radiologist, you do intervention, so you treat illnesses and medical conditions as well.
Yes, minimally invasive, low downtime, tiny little nicks in the skin and things like that, no major surgeries.
So tell us a little bit, before we get to how a specialty that you have around headache treatment, tell us a little bit about how radiologists do interventions through the tiny cuts and how you visualize what you're doing.
Okay, so what we do is we use, usually x-ray guidance to be able to see the anatomy of interest. And then because we're able to specifically see it, it eliminates the need of us having to make a large cut. We're able to go just directly over the anatomy that we're interested in, and with small needles or catheters, we can go directly into the area, treat it, and then take the needle out, and the procedure is complete with very little downtime and very little risk.
So tell us a little bit about how neuroradiology can play a part in headache treatment and maybe the evaluation, and then we can get to what kinds of patients would qualify, for that. But how is a neuroradiologist doing an intervention for a headache? Okay.
Well, in neuroradiology, our specialty is understanding, our primary benefit is understanding the anatomy very well. Mm-hmm. And not just understanding the anatomy, but understanding the imaging of the anatomy. So we're looking at, lateral views of the skull and understanding where all of the little curves in the bones are and what courses through there, knowing what nerves are in that area. Mm-hmm. And we can use that information and the image to be able to guide specifically to a certain part for treatment. Mm-hmm. Yeah.
And so in this case, where is this specific? I think it's very specific, maybe in the area you treat.
It is.
In the brain that is, where's the part of the anatomy that you're specifically treating with this intervention? Okay,
well, a lot of anatomy is named by where it is. Mm-hmm. And so this is in the location called the pterygopalatine fossa, mm-hmm. which is close to where the pterygoid bone and the palate come together. Mm-hmm. And the sphenoid bone this is called the sphenopalatine ganglion, is where I treat. Mm-hmm. And it's basically below the back of the orbits, mm-hmm. just underneath the skull base at the extreme back of the inside of the nose.
Okay, so you're above the palate, but behind the eyeballs, and then somewhere deep in the center,
right.
but still in the brain.
It's not in the brain, it's at the skull base.
I see, okay.
Yes, it's just underneath the skull base. Mm-hmm. So people think of their skull base, I think, as being, sort of flat, but it's mm-hmm. actually sort of angled. So the orbits, then the skull base sort of curves around and then meets the neck or the spine. Mm-hmm. So it's sort of angled as it goes through there, and that's the skull base, and it's at this angle where this little recess is, this little spoon-like area where this ganglion that we treat sits.
And when we say ganglion, is it a nodule? What is its normal function? What does it normally do for the
Its
brain
normal
or the
function,
body?
I tell my patients that basically think of the ganglion as like a computer relay box, or really the best analogy is, you know, Sarah from the Andy Griffith Show, Mayberry.
Oh, yes.
The telephone
yeah,
operator.
well, for those of people who know what a switchboard is.
The switchboard, that's right. It's like a switchboard.
This is the Siri of your brain.
In this ganglion is just a fancy word for a bundle of nerves where a lot of communication is occurring. So it really is just like a switchboard operator.
Wow.
So information comes in, it has to be appropriately relayed, and then it goes to the receiver, okay? In this case, the receiver is the brain, and then the receiver has to gain information from the call and then make a response. And then that information goes right back through the same switchboard and then back out, and that's the response to the stimulus.
And in this case, with people with headaches, is there an over-response to something that's happening? So it's over-activating
It
this
might be
system?
over, it might be under. What it is it's garbled.
I see.
It's not, it's just not right in one way or another. It's not necessarily an overstimulation, it might be an understimulation, but whatever it is, the communication is not as effective or efficient as it should be.
What kind of headaches are people having that lead a physician to believe this could be the culprit?
Headaches are generally divided into anterior pathway versus posterior. So this procedure that I do works only for the anterior pathway headaches, which thankfully the vast majority of headaches, including migraine headaches, are mediated through this pathway.
Was this something that neuroradiology or neurosurgery, was anyone ever working with this ganglion this way in the past?
Yes, absolutely. This, I tell patients that we've known about the ganglion and its involvement in these types of headaches for almost 100 years. And so the physiology behind this and, you know, the mediated pathway are all well known and well documented. But what's changed now is we have this new X-ray guided procedure where we can just go up the nose with no needles. And really it's the catheter technology of being able to get around the nasal passageways and get the catheter directly where it needs to be under guidance. And then actually we can just trickle the medication directly down into that spoon-like area. And the medication now has become so powerfully topical that it can actually soak in without having to be administered through a needle. I tell patients, you know, that are nervous about it, I mean, it literally is over in about 8 seconds. The catheter goes up the nose, and you can see it's about the size of a piece of spaghetti. And it has this gray part and then this coaxial purple part that allows me to angle. It's usually a little more angled than that, but it's been in my pocket.
Right.
And so it's very, very bendy and flexible, and I'm allowed, you know, that allows me to be able to move it around the internal fleshy parts of the nose and get it to where it needs to be. That's attached to a syringe that has the lidocaine and a little bit of X-ray contrast mixed together, and then those just go directly up the nose. I administer it, I see it under X-ray layer in that little spoon-like area, and then the catheter comes out and you're finished.
What have been the outcomes you've experienced or are in the evidence that you've seen?
We've had very, very good outcomes. We're averaging about a 90% success rate. And when we talk about success, in the vast majority of cases, we're not talking about 100% relief. What I tell patients, and of course I tailor this to the headache and their experience, but generally, if you're someone who's having 20 headache days a month or 20 headaches per month, and you're rating them between an 8 and a 10 out of 10 on the pain scale, that after the procedure has been completed, that you will maybe have 2 or 3 headaches per month, and their pain may not be worse than a 4 or 5.
So that's almost a 90% reduction in total headaches, right? 30 to 3-ish, and then relatively less pain in the ones you have.
That's right. Pain that is easily managed with over-the-counter medicines or, you know, some of the other migraine medications that they have.
What's the long-term efficacy after it's done? Are they coming back to see you how routinely?
Well, it varies from patient to patient because each patient's headache is a little bit different. But with a standard migraine patient, we're looking at, we do the procedure 3 times over 2 weeks, the first time the patient comes to see me. And that has just been generally found in the literature and experience that that's the best way to do it. And we get patients, we get their threshold for headache as low as we possibly can. After the 3rd one, we're averaging 4 to 6 months before they need another procedure.
So this is a procedure that has been around. Is there something, or has been here for at least as long as you mentioned, is there something that has changed about it that that more people are attracted to it, or is it just becoming just more well known?
It's becoming, well, it's both. It's becoming more well-known as we get the word out about it. And it's, you know, it's such an easy procedure to tolerate. You know, you just lie down on the x-ray table with, you know, face up. We tilt your head back a little bit. We take an image, the catheter goes up the right side of the nose, the medicine is administered, and then it goes up the left side, the medicine again administered, and then we throw the catheter away, and you lie there and wait while the medicine soaks in and does its job. And then after that, you sit up on the table and there's no downtime. Wow. There's no risk. You can go have a normal day, hopefully headache-free.
And do you think that, you mentioned the benefits lasting a certain amount of time or others, do you think that's just metabolically the way people process the lidocaine? It's that it's just going to work for some and it's going to work longer for others, but it doesn't work forever, in the sense that this is a treatment that is continual. If you have chronic headaches, this is a treatment you would have. Right.
What I tell people is when they come in, I say, you know, we don't really know exactly why in you you're having your headaches, what physiologically is wrong, but we know that you're having headaches 20 days a month and they're severe, and we know that there's just something about you that is, you're going to start to have this garbled communication in the ganglion at some point again. And so what we see and what patients tell us is that they've been headache-free for, you know, out in the community doing their job, happy, and then one day they have another bad migraine, and then they have another one the next day. And then they call and they say, I just am starting to have my headaches again, and then they just come back and have one procedure and they go again. And the good news is that this procedure generally is being shown that the more you have it, the more effective it becomes down the road.
Well, and it sounds like, to your point, I mean, and the benefit of being minimally invasive and having at least projected efficacy, you know, longer than a day, week, or if you're taking medicine, a day.
Absolutely.
Yeah. Well, thank you so much for telling us about that.
Yes, absolutely. Thank you.
Thank you. And thank you for joining us at Atrium Health Navicent Knows Health. If you'd like to know more about Dr. Evans and this procedure, please visit us at atriumhealthnavicent.org.